on Indian data on osteoporosis in patients with inflammatory rheumatic diseases.
May I start, sir? Thank you. Good morning to you. Today we will just have a brief overview of the Indian data on osteoporosis in inflammatory rheumatic diseases. I will keep it very, very brief. And आगे किससे करना? आगे इससे करना क्या? इधर नहीं जाना ना? नहीं. Yeah, sorry. So, you know, osteoporosis is a huge problem. It's an iceberg disease. The data, we have a lot of data as usual from US, but Indian data is lacking because many of them are not diagnosed because we don't even evaluate for osteoporosis in each clinic visit, and there is no large database. There are a lot of studies initially in the bone and joint decade of 2000-2010, but like most of the things, it is petered down. So what I did is a back of the card calculation. Like Indian population is about 1.4 billion, MSK prevalence is 13.26, and inflammatory rheumatic disease is 1.5%. So the prevalence of osteoporosis is 70 million, and estimation in musculoskeletal disease is 9 million, and in autoimmune rheumatic inflammatory disease is 1.5 million. This is again a lower estimate because this is the rough estimate, and there are a lot of reasons why we are not able to pick it up because of we don't have even a correct definition whether to use FRAX score or DEXA scan. The DEXA scan of hologic and lunar are not standardized for Indian population. It's standardized for Caucasians, though there are some ICMR modification, but there are a lot of confusion. And IRA website incidentally has got the most comprehensive data of the osteoporosis in rheumatic diseases. But you just see 1.4 to 68%. You see the spread, which shows that it's just a collection of various observational studies. But what I am going to do is just see what actually people have presented. This is the first one of a journal paper with Handa sir way back in 2008. But that was a journal paper on osteoporosis. And my friend Shankar initially had given a small prospective study, but it's just an observational study, used BMD. He found that 28% and in at least one side. See, the thing is, it's quite variation because it just captures, most of them are cross-sectional studies, so it just captures one part of the data. And Dr. Shafali from PGI, scleroderma, she had used FRAX score, but the probability for osteoporotic fracture is 22% and hip for 15%. She used linear regression model and with various coefficients. These are all, and this is the latest thing, but the crack study, Karnataka rheumatology study, wherein they have checked comorbidity specifically, but look at the paucity of data. Among the huge collection of various comorbidities, osteoporosis is here. Only one patient that picked up the data in rheumatoid, which most of them will have anyway. So much of, though this is a preliminary test, so much of less importance is given in osteoporosis because we just don't look at it at all. At least I am guilty of not looking at it every time because of various factors. So again, my friend Shankar has written a very good editorial in this last IJR. He just said time to tame the invisible gorilla, which means that if there is a basketball match occurring, and people are just concentrating on passing the how to see the passing the ball. A gorilla can as well walk through and through the court and you may miss it. So unless you deliberately search, evaluate, define and follow a protocol, it's very difficult to pick up this data. Of course, this was an attempt in 2019. Again, my friend Narendra Kotwal is there. They just told what are the position statement for diagnosis and treatment of osteoporosis in adults. This is, I think this is one article which you would like to see, just put, because this gives in detail what are the exact caveats, when to diagnose, how to follow, what drug to use in a very, very simple manner. So, so of course people have done osteoarthritis and in rheumatoid arthritis. This is a small series from Rajasthan, but here you had a contra results. People had less osteoporosis than the controls. So, and even in JAA there is a study from Prashant Agarwal a little back with Amita Agarwal ma'am, and so that's again, these are all cross-sectional studies, and one more from fibromyalgia from Danda sir from CMC. So I have just put in a nutshell for the want of time. See, these are the various studies, and most of them are case-controlled studies with small numbers, and so obviously we'll have a varied results, okay, because the numbers are too small. But I have just put up this reference with EMID, so if somebody wants to look up, we can look up. So it is just that we need to do a lot of data collection and try to put it up in a cohesive manner in this regard. Thank you.
Sir, that was a very good data, Indian data on osteoporosis. I would open the thing for questions if any are there.
Thank you.
We have the next speaker. Actually, it was the topic is Indian versus global data on premenopausal osteoporosis and rheumatic disease. A different story. The original speaker was Dr. Sifali Sharma, but now we have Dr. Saurav Malviya to present since Dr. Sifali had to leave early from Indore.
Sorry, ma'am's mother is not well. She has to leave early from Indore, and she went leave for yesterday in the evening. And she assigned me the role of presenting her talk. So I couldn't get the time, and just half an hour before I just read the slides, and I go to the slides, and then I'll try to present speak her case. So, Indian versus global data on premenopausal osteoporosis in rheumatic diseases are different story. So, moving. I will be blamed because I am in the organizing team for this. Sorry. Yeah. So, osteoporosis is a disease characterized by low mineral bone density, deterioration of bone tissue, destruction of bone marrow architecture, and compromised bone strength, and fractures. According to WHO, diagnostic definition of osteoporosis defined by BMD at hip or lumbar spine that is less than or equal to 2.5 standard deviations below BMD of young adult reference. I think so. It has been already been said by previous speakers. Global burden of osteoporosis. Using WHO definition of osteoporosis, the disease affects approximately 6% of men over the age of 50 and 20% of the women over the age globally. Based on the world population of men and women, this suggests that approximately 500 million men and women worldwide may be affected. And by 2050, the worldwide incidence of hip fractures in men is projected to increase by 310% and 240% in women compared to rates in 1990. So you can see the huge burden is going to increase, and in countries like India and poor economic countries, this figure may be high. You know how much research we are doing, how much epidemiological study we are doing. So I think so the burden of osteoporosis which is projected here is maybe more because of poor economic status in many countries, and because of diet issues and many issues, supplementary medications, steroid abuse by taking name of Ayurvedic medicines. This may be more. So worldwide, 1 in 3 women over age 50 will experience osteoporosis fractures, as will be 1 in 5 men over the age of 50. And osteoporosis is estimated to affect 200 million women worldwide. Epidemiology burden, Asia Pacific by 2050, about 1.3 billion people in Asia will be above age 60, and half of the billion of 80 years may be affected. Half of all infections will occur in Asia by 2050. So Asia is the global burden of the world of hip fractures and osteoporosis. In 2000, just 9 out of 100 people were aged 65 and over, and this number is expected to triple by 2050 to 27 and quadruple by 2146. So you can see half of the population. So and osteoporosis is the domain. You can say everyone is left. Maybe endocrine society or our society or physician forum, they have just left osteoporosis like a small disease. So half this horrifying data, 46% by 2021 is a horrifying data. So one has to take a call. So what about India? India is home to more than 1.3 people with over approximately 23 million Indians over 50 years. Most data on the prevalence of osteoporosis among women in India come from studies conducted in small groups spread across the country. And I attended the half talk of Dr. Shanmugan, and he has already shown actually. And these studies come in small groups, and estimates from 2015 have suggested that 20% of 23 million Indians women over age 50 years have osteoporosis. And prevalence of osteoporosis ranging from 8 to 62% in Indian women of different age groups has been reported in several studies. Prevalence of osteoporosis in males older than 50 is also variable, ranging from 8 to 24%. And I have seen the prevalence of osteoporosis in male is not studied. Why? What is the etiology, hormone? It has not been studied in many studies. It has not been studied properly in India. Extrapolating from the data, the number of hip fractures every year would be more than 4.4 lakh, with a female to male ratio of about 3:1, with a projected incidence of more than 6 lakh in 2020 and over 1 million in 2050. This is the burden of fractures due to low bone mineral density. These are the different color coding, right from 0 to 100 to more than 10 lakh in the orange. You can see in India, most of them is green. A community-based study to evaluate the prevalence of risk factors for osteoporosis among men in menopausal and premenopausal women by Dr. Kada and the team. They have studied in around 305 subjects and found that prevalence found that 14% of premenopausal women. Prevalence of osteoporosis is apparently healthy in adults above the 40 years of age in Pune city, studied by Kadam and all. A is the graph. You can see mean BMD with the age at lumbar and spine. This square one is postmenopausal women. This is premenopausal, and this is male. So you can see here at lumbar, the hip fracture, this incidence is quite horrifying, starting from the age of 40 years, 40 plus years. So this is lumbar region. This is left femur, this is postmenopausal woman, this is male, and this is premenopausal, and this is the left hip. So you can see lot of early onset of osteoporosis in Indian age groups. So what about GIOP? So this is what we rheumatologists should learn about. GIOP is much common in patients with rheumatic diseases also. So GIOP is the most common cause of secondary osteoporosis, is most common cause before age of 50 years, and most common iatrogenic cause of the disease. Prevalence of use of oral glucocorticoids in community population is between 0.5 to 0.9%, 65% of women, rising to 2.7 in the women. I think so this data may be misleading. It is much more in the form of puria, desi medications, Ayurvedic medications and all. Osteoporosis in autoimmune rheumatic diseases. OP among ARD can be attributed to multiple metal factors, inflammatory cytokines because of disease, use of medications, particular steroids, immobility, sedentary lifestyles, and in chronic inflammation, the balance between bone formation and bone resorption is skewed towards osteoclastic mediated bone resorption, thereby increasing the fracture risk. In RA, twofold increase risk of OP, and in SLE, you know, because of use of more steroids, it is 20% greater than the controls. What are risk factors? We all know these are risk factors, but smoke from right to smoking to low calcium diet to abuse of, you can say, drugs, genders and all, late menarche and other risk factors. Few are modifiable, few are not modifiable. What are diseases associated with osteoporosis? All autoimmune diseases, hyperthyroidism, acromegaly, other things. But we should not forget the drugs, steroids, heparin, PPI. Every other patient we use PPI in our patients while using DMARDs and immunosuppressants. OP in RA is of two types: localized to affected inflamed joints and generalized or systemic. Localized OP reflects disease activity. So as the disease activity gets better, OP gets better. So generalized OP is multifactorial because of inflammatory cytokines affecting osteoclastic physiology through rank ligands. Just finishing. Or WNA signaling pathway and drugs to manage RA and other risk factors. Lupus, it is mainly you have seen in women of childbearing age. OP in lupus is multifactorial because of hormones, low vitamin deficiency, drugs, because mainly cyclosporin, steroids, tacrolimus and others. And we lupus patients are used to avoid sun. So this may be the reason. Open spondyloarthropathy. Open spondyloarthropathy is most prevalent comorbidity with prevalence of spine osteoporosis, mainly reported range between 90 and 50%. Like other OP is multifactorial in these, cytokines play a role because of immobility is the other factors. But steroid is not the major factor in spondyloarthropathy because we don't use too much steroids in SPA and there is no role of steroids there. Conclusion: OP is in ARD is multifactorial. This includes traditional clinical risk factors, vitamin D, menopausal status, drugs, and many other contributing factors, inflammatory cytokines. Most studies support the role of rank-mediated and WNA signaling pathways in bone loss. Tight control of underlying inflammatory rheumatic disease is the first step towards prevention, in addition to addressing lifestyle modification and all. Thank you. I hope I could read her slides properly, and I definitely justice is not been the topic, but thanks for patient hearing.
Call upon the next speaker is Dr. Sujata Sandhi. She is a pediatric rheumatologist. She will speak about juvenile osteoporosis, what adult rheumatologists must also know.
Good morning, everybody, and I'd like to thank the organizers for giving me an opportunity to talk to you this morning. Let's change. आपका चेंज नहीं हो रहा है, इधर से करना है, कहाँ से करना है? Okay, so the remit for my talk today is to let the adult rheumatologists know what is the basics they need to know about juvenile osteoporosis. So we'll come away with a few concepts. So first of all, children are not little adults, and there are specific features about the child that we must know about. So children have growing skeletons, and children and adolescents, they accrue bone mass and they achieve peak bone mass in young adult years by the age of about 20 to 22. This achievement of the peak bone mass is impacted by many factors. Important amongst these are genetic factors, the amount of physical activity the child does, the adequate amount of vitamin D and calcium the patient takes, the fact that the nutrition should be very good, and that the child should be saved from systemic diseases and osteotoxic drugs. So, in children who have got a primary genetic cause that is driving the abnormal bone structure, that particular condition is called primary osteoporosis. And when children acquire osteoporosis because of modifiable reasons such as autoimmune diseases or the use of osteotoxic drugs, that whole group of conditions is called secondary osteoporosis. So in children who have primary osteoporosis, the recognition is usually by the pediatrician and the diagnosis has been reached by the time this child becomes an adult. Important amongst these genetic causes are children with osteogenesis imperfecta, but we also have a condition called juvenile idiopathic osteoporosis, and in fact there are many genes that drive abnormal type 1 collagen formation, the osteoblastic activity, the osteoclastic control, mineralization, and many of these conditions are going to present with early onset fractures, short stature, dysmorphism, blue sclerosis, significant hypermobility, scoliosis, and very important is a positive family history. So these children really don't come to the attention of the adult rheumatologist. What's the second important thing about children as compared to adult? Normal children have fractures, and normal children have fractures with exercise, activity and sport to the extent that about half of the children will have at least one fracture by the time they reach 16 years of age. Amongst the fractures, more than 2/3 are of the upper limb and more than half of the forearm. 25% do get lower limb fractures as well. Another very important thing about the pediatric skeleton is that children can heal and remodel the bone such that if a child, for example, under the age of 8 who's a girl or 9 who's a boy, has a vertebral fracture, then this patient has the ability to heal. And that is of course if the disease calms down and if the osteotoxic medication is taken away. And here's the example from a wonderful paper that shows us the spinal fracture in this child who had developed systemic onset arthritis and required steroids at the age of 18 months, and focus and look at the vertebral remodeling by the time the child is 10, that spine has become absolutely normal. So this is a phenomenal thing that children have. So keeping all these issues in mind, the International Society for Clinical Densitometry in 2013, which is revised its diagnosis of pediatric osteoporosis such that an isolated BMD abnormality on a DEXA scan is not diagnosable to give a diagnosis of juvenile osteoporosis. So what am I saying? If you have a vertebral fracture which is non-traumatic, regardless of the BMD, that patient will be classified to have osteoporosis. However, even in the presence of a low BMD, the child should have at least 2 long bone fractures before the age of 9 or 3 before the age of 19 to be diagnosed to have pediatric osteoporosis. Now these stringent criteria have been put forward so that normal children who develop fracture through play, for example, or high intensity trauma are not going to be evaluated for osteoporosis. But this strict definition has a lot of challenges. Important amongst these are that you actually want to identify a genetic cause of osteoporosis before the child has a fracture, let alone 2. If you have a patient who has glucocorticoid-induced osteoporosis, you're not going to wait for the second fracture before you decide to treat the patient. So there are some limitations of this particular definition which has been put forward. The other very important limitation is how do you identify a low energy trauma? So for children, a low energy trauma is one where the child falls from a height less than his or her own height. So that's very important. And secondly, the walking speed should be the maximum speed at which the child falls down. So if the child is running and falls from a lesser height, that also is considered to be significant trauma. The other very big issues when you are looking at the BMD report is the calculation of the Z score. So in children, we use the Z score, which is age and sex matched bone mineral density that the child has. And if you look at the various types of Z scores, there's a marked variability in the definition of the Z-score. So you have to be careful what is the machine and what is the Z-score calculation come to, and you must be very aware about that as you follow up these patients. And then we have children, for example, who have leukemia and can develop a spinal fracture in the absence of a lower bone mineral density. So these definitions are not to be used in an exact and absolute sense when you diagnose patients. And indeed, the clinical condition of differential osteoporosis, where only the spinal BMD goes down and the peripheral remains normal, is fairly classical of children with acute lymphoblastic leukemia, and these patients can come to you with severe bone pain of the spine, and remarkably the MRIs do not confirm the presence of leukemia. So very important to keep your eyes and ears open and take a detailed history for every child. Additionally, if a child is having recurrent forearm fractures or is having a long bone fracture with low trauma, you need to be careful about these patients. Remember that children can get fractures if they have non-accidental injury, and those children will have more than one fracture when you do a skeletal survey, and the fractures are of different ages. Some of these children have been traumatized by being shaken, and these patients also have retinal hemorrhages, but of course they may not come to you. Coming to vertebral fractures because of osteoporosis in children, so we need to know that a vast majority of these spinal fractures are silent. Diseases that impact systemically and where we use osteotoxic drugs often impact the vertebrae. So 75% of children with osteogenesis imperfecta will develop a spinal fracture, half of the children with Duchenne's will develop it, and 30% of the children with leukemia will have a vertebral fracture. So even a single vertebral fracture will require a very detailed evaluation in children. The bone mineral density on its own tends to underreport the strength of the bone, and therefore, tends to overreport the strength of the bone, and therefore if you are reliant only upon BMD to look at the vertebral bone strength, you are going to miss the child with an early vertebral fracture, such that the recommendation is when children, and I'll come to that in a moment, when children are on steroids, they need not only a dual side DEXA, but they also need a spinal X-ray as you evaluate them. And this paper very elegantly shows us that the child has got vertebral fractures with an anterior wedging, but here you can see that the DEXA scan is not picking up this abnormality. And so we need to understand that when you diagnose childhood osteoporosis, the diagnosis of the fracture and the further investigation for osteoporosis has to be nuanced. It depends upon the child, the family history, the nutritional status, the pubertal status, the presence or absence of systemic disease, the kind of fracture the child had, what kind of trauma was it. So several of these things are going to guide you to go ahead and evaluate the patient. So when you come to secondary osteoporosis, every child should first be investigated for a mineral metabolism abnormality, because if the child has rickets or an older one has osteomalacia, a softer bone is more likely to fracture. So before you go ahead and look at a whole list of causes, be careful about picking up the child with rickets. And we've had several children through the pandemic who had rickets and have fractured and have presented with osteoporotic fractures. Of course, amongst the systemic diseases that we look after, all of them that require significant steroid are the ones that are going to develop secondary osteoporosis. So when a child, for example, has juvenile arthritis, in addition to the use of steroids, what are the factors that are causing osteoporosis? Very similar to what happens in the adult world. So you have inflammatory cytokines, you have osteotoxic drugs, you have children who are not doing weight-bearing exercises, you have poor sunlight exposure, poor vitamin D generation, limited activity and poor nutrition, and all these things together are going to aggravate the presence of the childhood osteoporosis. How do you evaluate? Currently, the dual side DEXA scan is what is evaluated, but the data is currently available for whole body minus skull and for the vertebrae. We are currently not using the femoral DEXA scan report to diagnose lowered bone mineral density. However, newer papers are suggesting that now data is available for comparison. So, when you have a child who presents with significant fractures, you're going to try to understand, does the child have a primary genetic disorder, or does the child have a secondary cause, and accordingly you will go down this algorithm and evaluate the patient. Let's spend the last few minutes on glucocorticoid-induced osteoporosis in the pediatric population. So when you are using steroids in children, there's a double whammy, because first of all, steroids are affecting the chondrocytes of the growth plate and impacting the linear growth of the child, and you know that growth is what is actually helping the child to accrue bone mineral density, so that's knocked off. And secondly, at the bone which is already available, the steroids are inhibiting osteogenesis and increasing the osteoclastic activity, so that children have a double impact when they are given steroids. Now remember, when children are given steroids, the dosing of steroids can be divided in several ways. It is a low dose steroid if the total dose is less than 0.1 milligram per kg per day, and it's a high dose steroid if the dose is more than 0.1 milligram per kg per day. Additionally, there are some children on the left hand side, for example, who develop leukemia, who get an aggressive but transient steroid exposure, and these children, once the disease goes into remission, the steroids are withdrawn, we may not be very worried about ongoing osteoporosis. But from the rheumatology standpoint, inflammatory rheumatic diseases do have variable steroid exposure. Perhaps the worst hit is the child who is on long-term steroids, for example, the child with Duchenne's. Now, why do we have to know these? Because even though the child may have osteoporosis, we have to be cognizant of the fact that a small group of children may self-heal without using medication. A lot of the information that we have on how to manage the child with juvenile osteoporosis comes from the STOP study. This was a long-term 6-year prospective study that looked at in Canadian children the use of glucocorticoid and what was happening to the children, and what came out. Very important data came out. Vertebral fractures are the hallmark of GIOP. These fractures are often thoracic and lumbar. They are silent in a vast majority. They occur early, and 7% will fracture within a month. One vertebral fracture predates many others, so that these children have a cascading effect and develop multiple fractures. The BMD on its own is not going to pick up the silent vertebral fracture. You need to do a lateral X-ray spine. And though there is no critical steroid dosing defined, anything more than 0.1 milligram per kg per day for more than 3 months can cause trouble. As a clinician, when you have a patient on steroids, which children are you going to be very concerned about for the risk of GIOP? Those are the children who have a rapid increase in the BMI, who have a Cushingoid habitus, whose BMD decreases by more than 0.5 standard deviation in 6 months, and who have ongoing inflammatory rheumatic disease. And in pediatrics, we look at the vertebral fracture and classify them using the Genant scoring. And this looks at the difference between the anterior and posterior height. And depending upon the degree of collapse, the percentage drop increases, and that's how you classify children to have grade 1, grade 2 or grade 3 Genant scoring. And this is something which is routinely done in children who are on long-term steroids. And so what we need to know is that in the pediatric age group, because bone remodeling is there, every child with a vertebral osteoporotic fracture may not require, though I must say the vast majority do. What about the patient who's got systemic lupus or arthritis and you know is going to require long-term steroid, at least for 2 to 3 months as you wait for the DMARDs to take effect? There's only one trial, and we'll come to that. That is a preventative trial. There's only one trial, and this trial was not powered for fractures. It was only powered for either the accrual or the decrement of the bone mineral density. The current literature supports the use of only intravenous bisphosphonate once you have diagnosed GIOP in the child and once you decide to treat. There's no data, no class 1 evidence to support the use of oral bisphosphonates in children. So what's the algorithm that you want to use? So you've started glucocorticoids on a patient. You know the child is going to require more than 3 months. So what you want to do is to optimize everything else that you can do. So use a minimal possible dose of steroids, rapidly try to get the disease under remission, get the child to do enough physical activity, give adequate vitamin D, calcium, make sure the child is taking a balanced diet. Always give adequate amount of vitamin D, calcium. That's the hallmark as you want to try to prevent osteoporosis from occurring. Get your DEXA lateral X-ray done initially, and then every 6 to 12 months, depending upon how the child is doing. If the child complains of back pain at any time, that should trigger you to do a lateral X-ray, because your aim is to pick up an early vertebral fracture. Most of these children will develop vertebral fractures rather than developing long bone fractures. And if the child does develop a fracture, then like we discussed, think in your mind, look at the information available and try to understand whether this child is likely to self-heal. A small proportion may. Most of them are going to require therapy, and if they require therapy, you're going to use intravenous bisphosphonate. How long? Until the child has stopped using steroids and continuing for a year later. You don't abruptly stop bisphosphonates in children, because if you do that, the risk of the child developing a fracture actually sharply goes up in the months after you stop the bisphosphonate. Why is that? Because once you withdraw the bisphosphonate, the normal bone laying process begins, and that bone is soft as compared to the bone that was laid down when the child was on bisphosphonates, and it's at this level that the child develops a stress fracture. However, there's no data to support the development of osteonecrosis of the jaw or children getting spiral fractures when they are on long-term bisphosphonates. We tend not to use the bisphosphonate for more than 3 to 5 years. Then I told you that there's only one trial which has looked at the prevention of glucocorticoid-induced osteoporosis. That is to say, you use an anti-resorptive agent up front when you are starting the child on steroids. And this is a very elegant study which has been published in 2019. I don't know what is the reason why this is not commonplace in the pediatric rheumatology fraternity. And this is an elegant paper that looked at over 200 children who had systemic rheumatic disease and were commencing steroids. And these children were divided into 3 groups. They were given placebo, alpha-calcidol or risendronate. And you can see the purple dashed line, the Z score of the lumbar spine is the only one that improved with risendronate. There was a mild decrement when the patient was given alpha-calcidol and no change when the child was given a placebo. And the P score for the change in Z score was remarkably efficient and showed a very nice change as compared to placebo and alpha-calcidol. However, the increment of the BMD over 1 year was only 0.27, and we know that a significant increment in pediatrics is 0.5. This study was not powered to look at the rate of fractures, because for that you need to recruit several thousand children, and such a trial has never been done. So with all this information in the background, the 2017 GIOP guidelines of course are now redundant, because this talks about the use of oral bisphosphonates, and current data supports only the use of intravenous bisphosphonates. There is a Spanish position paper that suggests that if you are looking at children with rheumatic diseases, and as you follow them, they are having ongoing systemic disease and a falling BMD, and you now have a BMD which is more than -2 Z score, then those patients can be given a bisphosphonate. And if the child has an inactive systemic disease and has a BMD which is now less than -3, then those children should be given bisphosphonates. Again, these are very difficult because these are lower level evidence with expert groups but no class 1 evidence. We don't have any results currently for denosumab or zilindronate, and I'm sure you're all aware that for teriparatide, there's a black box US FDA warning that children are not to be given teriparatide because teriparatide is known to cause osteosarcomas in the pediatric population. So to conclude, I hope I've been able to convince you that children have specific growth related issues and their skeleton is very different to the mature adult skeleton, that a child can have either primary or secondary osteoporosis, that glucocorticoid induced osteoporosis usually presents with silent vertebral fractures that need aggressive screening. You need to be careful with a child who has GIOP and look at the background disease that is contributing to this, such that, for example, a 6-year-old child who is a female who has acute lymphoblastic leukemia, who develops a Genant type 1 fracture without any pain or alteration in the quality of life, whose disease has gone into remission, may not require any medication. On the other hand, if you have a child with class 4 lupus nephritis who's got a vertebral fracture with a Genant of 3 and significant pain, then of course you will want to treat that patient so that the management of these children is quite nuanced. The preventative strategy remains all the modifiable factors that we've spoken about. But even though we've discussed so much about osteoporosis in children, if tomorrow I have a patient who's a 14-year-old girl who has lupus nephritis, who's got aggressive disease, who requires ongoing steroids, we don't have any data to guide us whether or not we should be using upfront bisphosphonate in such a patient. And this data is not forthcoming because of the complexity of randomizing these patients and also looking at the confounders, which are the systemic disease activity, and there's no data available to support the use of bisphosphonates in such a class of patients. So thank you very much.
Thank you, madam. It was an excellent risk of the one is atypical femoral fractures and osteonecrosis of the jaw. Once we give bisphosphonates for longer duration. So what's in your practice, have you come across such patients and how have you dealt with them?
So, the children who may develop these complications are the ones who develop the primary osteoporosis, where you do not have any form of treatment except bisphosphonates. So that class of children with primary osteoporosis is not dealt with by us. They are dealt with by the genetic team, but the data says that they do not have a risk of developing either of the two things, spiral femoral fractures or osteonecrosis of the jaw. But what is the current guidelines? The current guidelines are that you use bisphosphonates in the standard dose, which is up to a maximum of 9 mg per kg per year. And as you find a BMD accrual, then you may want to space out the interval between the intravenous bisphosphonate. And I think the data is currently awaited on denosumab, and that may be a very good agent because that's an anabolic bone stimulant rather than just trying to reduce the resorption.
So audio.
Z-score done is less than -2. Even if there are no fractures, we go ahead with an intravenous bisphosphonate. I would like to know, ma'am, what you are doing in your practice.
So here's what we are doing. What we need to understand is that the remodeling of the bone in the pediatric population occurs, but it takes a very long time. So when you take this decision to give a bisphosphonate, you have to see what is the age of my patient, what is the pubertal status, ideally what is the bone age of the child, and what is the growth potential that this child has got left. So broadly speaking, if you have a child under 7 to 8 years of age, where you're starting on steroids, you don't need to be very worried about using upfront bisphosphonate, okay? Because this child has got the next 7-8 years to grow and accrue bone mineral density. So you really focus on making sure that your vitamin D is more than 30 nanogram per mil. So that is something we do quite aggressively. Every 6 months to 1 year, we keep tracking the vitamin D and making sure that's up. The second thing is that when you're giving calcium to these children, try to see that they're getting dietary calcium, because you're aware of the data that taking extraneous calcium can increase the adult risk of cardiovascular disease. And what we need to understand is that cardiovascular disease is not coming up in 5 years, it's a problem that begins in late teenage years, right? So under 8 years of age, vitamin D, calcium. Older children, say a 14-year-old girl who's had menarche at 11, whose bone age is equivalent to the chronological age, who does not have a lot of potential now to grow and requires steroid, that is a patient where I may lean on using oral bisphosphonate in addition to the steroid. In fact, remarkably, all the features when you give steroids to a child that suggest a high risk of GIOP also suggests a high risk of osteonecrosis, of avascular necrosis. So we see in our practice the child who has a rapid increase in weight, the child who becomes hugely Cushingoid, the child whose disease is active is the one who gets the AVN early on. So the other reason we tend to use steroids in the bisphosphonates in these patients is to try to see, is there a role of this drug to prevent AVN? Because AVN in young girls and boys is a very traumatic condition to have. So our approach would be nuanced, and in the absence of a fracture, in our practice, I don't use IV bisphosphonate now. Oral.
And second is, as you told, it may be sometimes asymptomatic fracture of vertebrae, so should we routinely screen them with X-rays?
Yes. So like I said to you, you should do a baseline screening for the children, including a lateral X-ray, because you know the systemic disease itself can give rise to a vertebral fracture. So there's a process in children that's called cascading fractures, So that if you develop one vertebral fracture, I don't know the exact physics and mechanics behind it, you tend to develop more and more fractures. Okay? So what you need to do is to be very careful about getting a DEXA and a lateral X-ray when you see the patient. Then if the child is going into remission, the systemic disease is calming down, your steroid dose is going down, you can get the next DEXA after 1 year. However, if you are concerned that the systemic disease is not quietening, that your dose of steroids is not coming down, then you could go ahead and get a lateral X-ray at 6 months. So it depends upon the patient that you follow.
And it's a very nice job is for this patient again have a fracture. So how long is it safe to continue this bisphosphonate therapy?
Yeah. So that's a very good question. I don't have the answer for that, nor does the literature. But all I can say is that you try to increase the interval between the bisphosphonate, and giving full dose for 3 to 5 years is okay. And the majority of the patients don't tend to require that later on. So there is 2 trials which have been done. There's been a trial on the use of denosumab in inflammatory rheumatic diseases, and our center participated in it. So that trial is now closed, and we are waiting for the results to come. But we must say that we were able to recruit only 1 child for the trial. But I must say that the accrual of bone mineral density with denosumab in the single patient was really remarkable. So I think that you will get the results in the next year, and then denosumab may be another agent that can be safely used. So you can't really change the agent like you can do in adults because we have no data. The patients with osteogenesis imperfecta are now being switched to zoledronate, but the effect of the bisphosphonate seems to be about the same. It's just that zoledronate is much more potent than palmitronate, and perhaps a little more convenient because you can go to 6 monthly dosing. You are, as far as teriparatide is concerned, it's a black box warning. So they had these rats where they gave teriparatide, and those rats developed osteosarcoma. But there's a lot of criticism about that model, the animal model, because the dose of bisphosphonates used was more than 50 times than what is used for the humans. But in view of the fact that this is published data, using teriparatide is a complete no-no. So I think the answer will come from switching the agent to denosumab.
I have also good morning and fractures. If we providing physiotherapy with these, so it may be subside these, or we prevent different side effects of these steroids.
That's a very good question. So you know that there's a lot of information out there that when a child has got a systemic rheumatic disease, is or is not on steroids, what kind of physiotherapy should that patient be doing? The physiotherapy that patient should be doing should be low frequency, weight bearing, strength training, where you're going to have the muscle that is pulling at the bone. So what is that called? That's called the mechanostat theory, where you want to have the muscle creating the tensile strength on the bone, and that is what is going to help you to counter osteoporosis. So to increase the BMD, exercises should be weight bearing, and an exercise like cycling or swimming, which is very good for all-round fitness, is not the best exercise for BMD. But it's a double-edged sword, because as you encourage the child for weight bearing exercises, their sporting activity goes up, and they are then prone to get the high impact fracture that 1 in 2 children get by the age of 16. So you have to tread the line carefully, but you're absolutely right. So like I said, exercise, nutrition, vitamin D, calcium, control the disease, limit the steroid, all these things you must do to try and prevent these complications in children.
Thank you so much, ma'am.
It was a fantastic talk. What is the bisphosphonate you commonly use for children?
So while I was studying, and preparing the talk, I understand that risendronate is better than alendronate, but regrettably we are using alendronate. I see that risendronate is the next generation bisphosphonate, is more potent, but I know traditionally just use alendronate. You need to be careful about the dose of alendronate, so that a child whose weight is less than 30 kg should get 35 milligram, and someone more than 30 kg can get 70 milligram. We tend to go for the weekly dosing because it's very difficult to get the children, especially the rebellious teenage girls, to take the medicine empty stomach every morning, not lie down, eat, drink, for 30 minutes after the drug. That's not going to happen. So we have to negotiate and mostly use weekly. Again, in our practice, we've not really used abandonate. The issue with all these drugs is that they come in single pill sizes, and we know that we should not score the oral bisphosphonate. So we are limited in what we can use.
Thank you, madam. It was a wonderful session. I think we'll come to close the session now. Thank you so much.
Thank you.
Person and all our speakers. I would now like to invite the session coordinator for the next session to take the dice. Thank you.